So you had some exposure to NBI, but routinely were you doing NBI in your unit during training? No. Where is your, there he is. Dhaval, what about you? Sit. Were you exposed to NBI during your training?
So we didn't have that one NBI that time.
No. But subsequently now that you are here, you are doing NBI routinely?
So since last 1
Here.
year I am doing it.
Okay. So I just want to understand where do we all stand in terms of NBI and advanced imaging? Is how, if I were to put in a scale of 0 to 10, 0 is I don't know anything, and 10 is you are an expert like Sano or Rajinder Singh or whoever it is. Where do you stand? 6. What about you, Prithvi? 6. No. What about you, Kunal?
1 or 2.
1 or 2. Okay. What do you, Rakesh? 1 or 2. 1. Okay. All right. And Chirag is 10? All right. You'll, why don't, can you put this closer to you? No. All right. So what I'm going to do is basically go through some of these issues during the talk, and the way I have decided is I will talk to you about something and then we go into the patient, try and see some of those things so that whatever you've seen you learn to apply, and during the thing there, whoever is using the endoscope, I don't intend doing the procedure except standing behind you. I will guide you through the steps and the techniques to do it, and maybe some of you can use the scope yourself and see how you use the knobs, see how you actually get to image. Okay, next slide. So some of these things we've discussed yesterday is that the whole thing about doing advanced endoscopy is having the right kind of equipment, high resolution monitor scopes, high definition monitors to see whatever we are seeing more clearly, right? And we have, of course, optical magnification that we have with our some of our Olympus scopes. Next. And you have various other things of improving detection with Wilder field or LCI with Fuji. You have a computer-aided diagnosis and so on. These are basically red flagging techniques to make sure that your miss rate is less. About narrowband imaging, very simple. White light is split into the spectrum from violet to red, and then you use just these two components and use that to get a better imaging of the superficial layers. Because remember that why is NBI developed or any other modalities developed is primarily to increase our pickup for mucosal cancers. And we all know mucosal cancers start in the mucosa. And the earliest changes will be the surface changes and what happens in those vessels. So any technique that helps us see those vessels better would be the modality to go through, and that is what we exploit when we get these images. Basically we are looking at whatever gets reflected in the superficial layers. We are not so worried about the wall. To see the rest of the wall and things like that, we have EUS and other modalities that look at it. Next slide. So this is, I think, the most important slide for all of us, is that if you want to do good quality endoscopy, you must sedate the patient. A patient who is jumping around on the bed and thing is not going to be, because your entire attention is going to see, is he going to chew up the scope? Scope damage hoga, kya hoga? You're worried about that. So, you know, your one hand is there rather than focusing on the screen. Use Buscopan as and when necessary. We don't use it routinely. But yes, if we have issues, we certainly use Buscopan. We obviously want a clean field. There's no doubt about that. A clean field means the patient has to be fasting. I discussed this last night. We must have a patient who's adequately fasting, nothing in the stomach, maybe a pre-endoscopic drink of simethicone with obviously acetylcysteine does make a difference. We usually use a cap when we are doing this so that we get a good focus. I will talk about this again. Acetic acid is something I keep in my unit, and we'll see why during the procedures, but this is important. When you are in the endoscopy room, forget about what's happening in the outpatient. Never have you start endoscopy and your secretary comes and says, sir, 7 patient wait kar rahe hain, sir. Sir, MLA साहब आए हैं, sir. Corporator साहब बैठे हैं, sir. Now those are sure signs that you're not going to do that endoscopy properly. So you have to learn to dissociate and give enough time. How much time do you think we need to give for a good upper GI endoscopy? 8 to 10 minutes. Okay, how much do you give yourself?
I just do diagnostics, I think 6 minutes.
6, okay. All right. What do you say though? All right. So the figure that's quoted is about 7 minutes. All right. So you don't need 10 minutes and think, and believe me, it actually doesn't take 10 minutes. It doesn't even take 7 minutes unless you are interrogating something. A routine you can finish with experience. You can quickly make a thing and say, okay, no, all this looks normal. Then you say, oh, yahan kuch lag raha hai, I'm going to interrogate, you may be spending another extra minute on it. So it really does not take that much time. I have a lot of people telling me we have do lots of endoscopies, I can't give more than 2 minutes, 3 minutes. But believe me, once you get experience, it actually doesn't take more than 4 minutes, 5 minutes. So please don't start off with a negative thinking, mere se nahi hoga. Don't do that. Everyone can do it, just going to take, you know, that little extra time, and it makes a big difference. One of the most important things is insufflation. When you are in the stomach, insufflate. If you don't insufflate enough, you're going to have these folds and it's very easy to miss. Next slide. Next slide. See this? A lesion may be there which can be easily thick. So in the stomach, make sure that you've inflated. Of course, you need to deflate at the end of the examination. That goes without saying. But insufflation, these are, I'm talking even without NBI, what you can do with white light endoscopy. So patience, sedation, good quiet patient, clean field, insufflate, look at it systematically. Next slide. Now we're talking about caps, and why do we use caps? We have different kind of caps. There's a black rubber hood, which is a soft cap, and then you have the more a little harder cap which you have. You can use, I prefer to use the soft cap, and that is just kept at the tip. Now why do we do this? The idea is to get a good focus, so that, and it is stays there and the field doesn't move around too much. So rubber cap is a good idea. We'll show that when we're doing the procedures. This is much more useful when you're doing therapeutic work. Again, to keep your field, keep your accessories thing, and sort of focus well on that. Next slide. Look at this. Now this, if you use a without attachment, now your wall or the mucosa is going to come into opposition this way. And look at the image that you're getting. You're getting a kind of a tangential image. This area is blurred, this area is blurred, this is the thing. But if you can get a thing with a cap, look at this. The entire field is uniformly assessed because when you're looking at it with high magnification, you need to have this entire thing. So very simple thing is to use a cap. And next slide, and how do you use a cap? Yeah. See, when you use a cap, if you do this and go in this angle, what will happen is you'll push against and it will cause trauma. And we know that any advanced imaging, one of the worst things apart from a dirty field is to have blood smearing. Once you have blood smearing, you can't do anything much. So approach it this way and then gently suck so that the whole thing comes up. Maybe put a little water and then adjust, and you're very nicely, snugly sitting there without traumatizing mucosa and can visualize. This takes a little time to master the technique. I think the best guy that I have seen is Professor Kenshi Yao. He's about the only guy in Japan who's that good at it. No one else is that. So he's really at 10 plus. Most of us are at about 5. Okay? Next slide. The other thing is to again go back to your histology and know what is your levels. You have the epithelium, you have the lamina propria, muscularis mucosae, submucosa, and muscularis propria, and of course the cirrhosis are down there. What we can see when you do an EUS is all these layers. But when we do endoscopy, we are really trying to focus on these layers here to find out changes. And this is in situ lesions, this is T1A, T1B. So this is all T1. In oncology, I think this will be early. But how early, whether it's endoscopically resectable, will depend. Endoscopically resectable would be this, somewhere here. If it comes here, that means it's closer to the muscularis. So understanding this and familiarizing yourself with these terms is important, because everyone keeps talking about T1, T1A, and so on. But this is what it really means. Next slide. The other thing is Paris. I spoke to you last night as well. This is something that you must be familiar with, because it tells you a lot. And this is something you can do with white light endoscopy. Someone said you use 170 scopes. This you can do without any problem. So this is the classical pedunculated polyp 1P. P is for pedunculated, 1 subpedunculated, 1S is sessile, and then you have the flat lesions, 02A, 02B, 02C with a little depression, and combinations. So the dangerous ones are when you see 2C, 02C. So very superficial lesion. When you see a depression, we'll again, let's see if we see some lesions, we should see how we can classify. And this should be brought into your reporting format as well. Say for example, you say, I see a solitary lesion in the antrum, which appears a little red, indistinct borders, 02A, measuring about 4 millimeters on the, at the incisura, on the, there's a curve or whatever it is. Right? So all that should come in. Next slide. So I'll just show you normal appearances of esophagus and stomach, and then we will. In the meantime, you can ask them to have the first patient on the table, and we'll be ready. If it needs. So what do we see on here when we use NBI? We see this. This green thing is the vein. And these sperm-like structures are the intraepithelial papillary capillary loops, IPCLs. Right? So when we see, we look for these IPCLs, and this is normal. So when you just kind of imagine this, this will be, if it now becomes more denser, you say increased number of IPCLs. Right? You see many more. Or if they appear, don't appear like sperms with sperm heads, then you say they are abnormal. And we'll see what those abnormals will later. But learn to recognize what is normal. Right? So you must see this and this. That's all that you will see. So IPCLs is only for squamous epithelium. It's not for columnar epithelium. Please don't write stomach does not show IPCLs. You're not going to find it. You can't extrapolate. What is seen in this organ is seen for this organ. What is seen in the stomach is something else. What you see in the colon is something else. You can't say the same classification for the stomach you're going to use for the colon. What is for the colon to the stomach? No. So that's why I'm going to split it as 3 distinct: esophagus, stomach, and even in the esophagus, I don't know, there's this lower part, G junction part of it is going to be different, more like stomach. Next slide. Okay. Now stomach, we have 2 main areas, the body and the antrum. And in the body, this is what it normally looks like. And these dark structures are the veins, the collecting venules. And what this is the background is, this is what I call the beehive pattern. B for body. Okay, this hexagonal kind of thing is the pit pattern in the stomach. So this is what it looks, and you find these collecting venules. So the abnormalities may be, you may not see the collecting venules, or you may not see this pattern, you may see some other pattern, or it may be obscured, or whatever. So this is normal. Next slide. So these round or oval pits that you see collecting, the honeycomb pattern of the, okay. Just go to the next slide. Okay, now if you see this a little more clearer, this is with the NBI with magnification. You see the collecting venules, no problem. Now when you see this, you have the boundaries of this, all right, this hexagonal. Those are the capillary network. That's the capillary network. In the middle is the pit. Okay, so these pits are oval to round, but the boundaries are like a hexagon, right? Like a thing of a beehive, and you see these greenish collecting venules. So just keep this in mind. With the older scopes, your 170 scopes, if you're NBI, you'll see, were those lights off? Okay, I'm sorry. Maybe this light we can put off. Is it better now? Kunal?
Yes.
No, no. Okay. You're able to appreciate this? Next slide. So this is exactly what you're seeing. If you take a cross section here, blood vessels, right, the crypt opening, this is what you're seeing. This is in the body. And this is called the, what you see around here, that's the marginal crypt epithelium, right? This part. And the brownish is the vessels. Next slide. Now when you come to the antrum, it's a little different. We know that if you go, I didn't remember what I read in anatomy, but so I learned it again now, is that the glands are not straight. They are more sort of angled. So when you take a cross section, you will not see that beehive kind of pattern. And so they look like little grooves, groove pattern, or like gyriform pattern, if you want to call it. And the blood vessels therefore appear within as curled kind of thing, little wavy kind of thing. And the things you can make out this pattern like the gyriform pattern. So this is a typical appearance of the antrum, right? Now you don't see collecting venules here. Normally collecting venules are not well seen in the antrum. It's only seen in the body. So if you want to look at collecting venules and say are they present or absent, look at it in the body. Don't look at it in the antrum. All right? Next slide. So no collecting venules, coiled subepithelial this brownish ones, and a tubular and or a reticular pattern. Next slide. Lastly is when you see the stomach, how do you start? Antegrade view, antrum, look at it, look at the lower body, look at the, come back, middle upper body, retroflex, look at the fundus cardia, mid upper body. So this is how you must document. And typically when you do the procedure, I'll show that thing, is when you do NBI, whatever, you see, now you've got to the antrum, now you're looking at the pylorus there, you freeze. Freeze, and then you say, okay, now I have a picture like this. You look at one quadrant here, this quadrant, this quadrant, this quadrant. Look at all the 4 quadrants and say, do they all look all right? Do they look the same? So that's how you look at it. And once you get trained, it's very quickly. In fact, once you have some experience, just even when your younger colleague is putting the scope, you say, no, I saw some lesion here, I saw something here. That's how you train your eyes. Okay? So this is how you document for the stomach. So similarly with the esophagus, you're going to have a look when you're going in, distend, have a look, and again when you're coming back, you have a look. A lot of us put the NBI when we are coming back, but when we are going in, we go in white light, and if we see nothing abnormal, when we are coming back, we put a NBI to see if it looks normal. Next slide. I think that's where I stop, I think. Okay, we'll come to this later. We'll come to this later. Okay, shall we go to the thing? Who's going to do?